So we are starting with another session of medicine with Dr. Aastha Poddar, and we're going to discuss the topic cough from Harrison. So let's get started. So we all know that cough is nothing but a protective mechanism, so that if we have any kind of retained secretions, then we can get rid of them. So now I'm gonna share my screen with you. So cough is nothing but basically a reflex mechanism of our body to get rid of a certain any kind of secretions which are there, or if any kind of stimulus is provided. So let's start the story of cough. So what happens is that you have some kind of stimulus. Now, first it could be any chemical stimulus, or it could be any particulate stimulus. And so you get that stimulus, and when you get the stimuli, some receptors are activated. So the chemical stimuli can be capsaicin, and the mechanical stimuli could be something like mucus particles or air pollutants which you might have inhaled and has traveled down your trachea and into the lungs. So as you can see here, so you have, yeah. So when you look at this diagram, you see that this is your basically nasal cavity, and then nasopharynx, oropharynx, larynx, trachea, and then you can imagine the rest of the bronchial tree below that. And so you see that whenever this yellow thing, which represents the stimuli, so whenever this will be activated, this activates these receptors, and when it activates these receptors, the cough reflex is triggered. So now, does anyone know what kind of receptors are there for sensing these stimuli? So basically, there are two kinds of yeah.
Mechanosensory and chemosensory receptors.
Yeah, so there are sensory receptors, first of all, and the sensory receptors are of two types. One is the cationic channels, okay, which are basically transient receptor potential channels. And the second is the ATP channels, ATP activated ion channels, okay, which is also called P2X3. So these two channels, basically, they are working as receptors, they are being stimulated, and then afferent nerves come into play. So then transient signals are transmitted. So signals go to the brain, from brain the signals come to the muscles, and then the full cuff reflex is initiated. So basically what happens, you have receptors, and then you have afferent nerve endings. Afferent nerve endings are nothing but basically A means arrive, so these nerves arrive to the central nervous system. So these afferent nerve endings are mostly vagus nerve and the superior laryngeal nerve. So these go to the brain, a particular area in the brain which is called solitarius, nucleus tractus solitarius, okay, which is in the brain stem. So now the stimulus came, it activated these receptors, and then the afferent signals travel through the afferent nerves like vagus nerve and superior laryngeal nerve. And you have to know that the areas which are richly innervated is this the pharynx, so nasopharynx and oropharynx, the larynx, the trachea, and airways up to the terminal bronchioles and lung parenchyma. And why is this important? Why do we need to know that? So the reason is that anything which will be stimulating any of these areas will lead to cough. So I want you to think of it with respect to pathologies. So that means that anything that is in the area of the pharynx, like the postnasal drip, right, or some kind of inflammation, throat inflammation in this area, can stimulate these receptors and in turn causes cough with this particular mechanism. And also anything which is down till your parenchyma, lung parenchyma, will also go through this mechanism and cause cough. But the catch is that the most common test which you usually do to determine cough is basically your chest x-ray, and the chest x-ray is positive only if it is, in the lung parenchyma. So the things which are stimulating these nerves, which are not appearing in the chest x-ray, are causing cough, and for those conditions the chest x-ray is going to be negative. Also, there are two more interesting things which also activate have these afferent nerve endings with them. That is the external auditory canal and the esophagus. So why is these two important? So when a patient has cough and they don't they have a negative chest X-ray, at that point you see that um, if they have a negative chest x-ray and they are having cough and you're not suspecting any of the pathologies within this tract, then you feel that okay, maybe there's some kind of impaction in the external auditory canal, which is stimulating the auricular branch of the vagus nerve and causing this whole cough mechanism, from vagus nerve to the nucleus tractus solitarius in the brainstem, and then again going through the efferent nerves. Or if there is a lesser known cause which is called GERD, okay, gastroesophageal reflux disease, that also causes cough sometimes, and the mechanism behind it is this, that these nerve endings in the esophagus are stimulated and they lead to cough, because when these nerve endings are stimulated, again they go to the nucleus tractus solitarius and then the efferent signals come into play. So efferent nerve signals, so efferent nerve basically orchestrate a series of involuntary muscular actions which lead to cough. Okay, but also the efferent nerves also have a potential to get an input from the cortical pathway. So that is why the cough can also be voluntary. So we have gone through the initial mechanism, that okay, there was some stimuli, whether in the nasopharynx, pharynx, in the trachea, in the lung parenchyma, and then it traveled through the vagus nerve or superior laryngeal nerve, and then it went to the nucleus tractus solitarius in our brainstem, and then from there the efferent nerves are coming now and orchestrating this complex involuntary muscular actions, and some cortical pathways are coming in. And in it, so what does it do? So what it leads to is that it causes the adduction of the vocal cords. Okay, so now I want you to see this diagram here. So this is your epiglottis, this is the nasopharynx, oropharynx, and these are the vocal cords. So now these vocal cords close. Okay, and when they close, there will be obstruction of this upper airway, and this will generate what? A pressure, right? Intrathoracic pressure will be generated downstream this, because here it is completely obstructed. So you took a deep breath and then immediately the vocal cords got adducted, and then a positive pressure is generated, and they say that it's approximately 300 mmHg of pressure is generated. So this intrathoracic pressure generates, and then there is sudden release of these laryngeal contractions, and then there is a rapid expiratory flow is generated. So how is this gonna help us? So in addition to these, even the bronchial smooth muscles, they contract, and there's dynamic compression of the airway lumen. So now what is happening is that basically you are narrowing the lumen inside your airways, and if you do that, there will be maximum velocity will be generated with which the air will be expelled. So now that is the velocity of air and the kinetic energy which you require to dislodge that particular mucus which was irritating your airways and which led to this cough, stimulus of cough. So it maximizes the velocity of exhalation and dislodges the mucus inside the airway walls. Do you guys have any doubts up until here? Okay. So now I have a question for you, that how do we know if the cough was good enough? Because there are conditions when the cough isn't that good, or so how do you know that the cough is good enough? So you can assess it qualitatively with the help of peak expiratory flow or maximal expiratory pressure. Okay, and you can use that to know if the cough is good or not. So when can anyone tell me few conditions when the cough is not good enough?
Hello.
Yeah.
Yes, so some conditions that I guess would be associated with a cough that is not good enough are wound over the chest or over the abdominal wall, which can lead to, we can lead to the patient feeling pain when they cough. And
Yeah.
some other conditions might include the patient suffering from conditions like cystic fibrosis, in which the patient has thick mucus, so he can't cough it up. So I
Okay.
think those are some conditions.
Yeah, very, very good. These are excellent examples of few conditions which can, like you said, so how I like to kind of organize it in my brain is that you made a very good point that, chest wall can be involved, or there could be some way where there is obstruction in the airway, and because of the inability to clear that obstruction, you can have impaired cough. So talking about the chest wall, there could be respiratory muscle weakness, or there could be abdominal pain, and if like post surgery in particular. So if there's abdominal pain due to any reason, or if it is post surgical as well, then in those cases what happens is that the patient, when they cough, they feel pain. So these are, and then kyphoscoliosis is another chest wall abnormality. Then tracheostomy or impaired glottic closure is another. Then, if there is respiratory depression for some reason, so now we are going from the external factors of our body, like the chest wall, or the impaired glottic closure, because I told you that initially you inhale, and then when the cough is being generated, your glottics close. So if they are not working properly, again you will not generate a proper cough. And then going further down, if then it is the afferent signals travel to the central nervous system. So if the central nervous system is depressed, then there will be improper cough. Okay, so in cases of anesthesia, sedation, or any neurologic condition. And then if the secretions are too much, or if the secretions are also cleared with the help of cilia, so if the cilia aren't functioning properly, like ciliary dysfunction, and if there is tracheobronchomalacia, bronchiectasis, so all these things kind of assist in having improper cough. And the way you can help your patients, so there are two methods. One is a very simple method, where mostly what you do is that you splint the abdominal muscle. So you ask the patient that you can place a pillow tightly. You can hold the pillow uh, in front of your abdomen, and that will reduce the post op pain while coughing. So that is one. Second is a little bit complex, and that is basically a mechanical cough assist device, which is basically supplied via face mask or a tracheal tube, and that applies a cycle of pressures to rapidly generate that negative pressure, which we talked about during the mechanism. So there can be an external device, and they can be simple. Okay, I see that Prabhat is raising his hand. Do you want to say something?
Hello, yeah. If I may, I just wanted to add something here.
Yeah,
So,
sure.
yeah, so one thing that I noticed, that I observed while treating patients of COPD that is not covered in this list is in patients with COPD or any other causes of respiratory distress, the patient is breathing too rapidly, which leads to his inability to to have a effective cough reflex. So the patient is breathing so rapidly that he also coughs, but his cough is not effective enough to clear his secretion. So that is one